Good evening, everyone, and thank you for making time for our fireside chat today. Today is going to be a 189th series of the AHN fireside chat, and today we are going to kick off a series of teachings, and we're going to start with a pragmatic series, being practical, and that's why this time we are shifting gears to the surgical bit. And the topic for this day is on parathyroidectomy in CKD and its surgical training into Africa. So my job today will just to be introduce the moderator for the session. And then in turn, we'll introduce the speaker and the topic. But before I do that, I just want to briefly, again, thank the team for making time, because we do know that the effects of CKD-induced hyperparathyroidism can be quite devastating. And the lack of, again, specialized surgeons does present significant challenges. But seeing that we do have a potential solution emerging, one that could actually extend across East Africa, as you're seeing that we're able to capacity build and also train teams across and also share knowledge. This is truly remarkable and transformative opportunity for the region. And we at AHN are incredibly excited and deeply grateful for this initiative and the dedication behind it. The impact of this effort will be profound, bringing much needed hope and care to countless patients. So thank you for making this vision a reality, Dr. Davis and Dr. Kristin. So I'll just briefly introduce Dr. Davis, who will be the moderator for this session. So Dr. Davis is a general surgeon and a current head of surgery at AIC Kijabe Hospital in Kenya, where he has worked full-time since 2007. He has also served as a medical director and program director, the general surgery residency. He completed his general surgery residency training and medical school, both at Creighton University, School of Medicine in Omaha, Nebraska. He is a fellow by examination of the College of Surgeons of Eastern, Central, and Southern Africa, and a faculty member of the Pan-African Academy of Christian Surgeons. So over to you, Dr. Davis. You can introduce our guest speaker for this evening. Thank you.
Thank you, Yuri. Dr. Oketch, I really appreciate it. It is my pleasure to introduce Dr. Long. She is a friend of mine. I've met her at several COSECSA examinations and quickly realized that she was a kindred spirit. She went to medical school at Texas Tech University, followed by general surgery residency at University of Kentucky, and then a subspecialty fellowship training at MD Anderson Cancer Center. This was in endocrine surgery. We were just discussing what endocrine surgery is. It's a specialty that deals with hormonal disturbances, surgical treatment of hormonal disturbances of the thyroid, parathyroid, and adrenal glands. And she was telling us about 70% of her practice is parathyroid surgery. She has done more than 1,000 parathyroid surgeries, so she is very, very experienced in talking about this with us. One more thing I want to mention, besides being examiner in COSECSA, as I said, she is the president-elect of the Association of Academic Global Surgery. Many of you might be wondering, what is global surgery? Actually, I hope I get this definition right, but global surgery is concerned with the disparities between the developed world and the developing world, specifically surgical capacity, and it is looking for solutions in that to these problems in the domains of advocacy, teaching, research, and clinical work. And we hope that the clinical work would be sort of furthering those other three along. As you're doing clinical work, you're also teaching. As you're doing clinical work, you're also thinking about things that could be made better in the form of advocacy or research. So that endocrine surgery and global surgery are Dr. Long's passions, and that is why she is here today. So welcome and thank you.
Thank you so much for that super kind introduction. I think this is a really, really exciting time for me because, as I was just talking in clinic earlier today, it's taken about 10 years, but my clinical passion for parathyroid disease and my academic passion of global surgery are finally meeting in a way that we can practically bring this to the region. And I was so excited to hear the introduction talking about this being a very pragmatic series, because I think that's really one of the things that we can think about with parathyroid surgery. I love it. It's my favorite thing to do. And, you know, it's something that technically I think can be easily trained into the region. Some of the challenges are going to be just in how we adapt the pre and post-operative care of the patient. So I'm going to attempt to share some slides. Let me just bring this up and you guys let me know if this looks. So briefly, just wanted to give a little bit of a background of how I think about parathyroid disease and how we treat it surgically. And this will probably take about 20 to 30 minutes max, and then hopefully have a lot of time for questions and discussion, because as we alluded to, kind of the trick to this particular version of parathyroid disease is in the pre and post-op management and the patient selection, which is something that's going to take a lot of planning. And in the realm of global surgery, you know, our primary focus is making sure that we're helping more than we're hurting. And I have no interest in doing something that we can't properly take care of patients and provide benefits. So I have no financial disclosures. I'm not paid to do this work. I pay for the privilege and I'm happy to do it. So as I've said, I am a bit of a parathyroid nerd. I love this tiny little organ more than almost anything else. It is, interestingly, it was the last organ discovered in the human body so far, as a very astute medical student pointed out to me not too long ago. The parathyroid glands typically live here around the thyroid, kind of on the corners, if they're following the anatomy rule book, and they're known as the glands of Owen. And I think this is such a fascinating story if you're ever interested in sort of surgical history or how we got to this. But the picture here on the left is Sir Richard Owen, who is a British anatomist who had the right of first refusal for any animal that died at the London Zoo. And basically what happened is a rhinoceros, which is pictured here on the right, died at the London Zoo, and they hauled it to his house and he was able to dissect it. And that's the first description of the parathyroid glands. So they're often known as the glands of Owen. We in the realm of endocrine surgery are, again, giant nerds and have adopted the rhinoceros as our mascot. So if you see me with something rhinoceros related, it's because it has to do with the parathyroid glands. And thankfully, the parathyroid glands in the rhinoceros were quite larger than they are in the humans, because they are quite difficult to find. And that's one of the biggest struggles of parathyroid surgery, is it sometimes, you know, it's one of the few scenarios where we're operating on something and might actually have to go tell the family we couldn't find it, right? You can generally always find the gallbladder or the colon or other things that we might be operating on, but the parathyroid glands are very sneaky. And so there's a lot of intraoperative decision making. And I think it's something that you need a lot of experience to manage well. So what does parathyroid hormone do? And to some extent, I'm sure I'm preaching a little bit to the choir in terms of these roles, but parathyroid hormone basically has three main roles. The first thing it's going to do after it's secreted from the parathyroid glands is increase calcium uptake and resorption by the kidneys. It's going to stimulate calcium release from the bones, and it's going to activate vitamin D. And that will then lead to an increase in calcium absorption from in the gut. So what happens when the system is working as it should is, if the calcium level is elevated, the parathyroid hormone should go down. And I explain this to patients like a teeter-totter. And what happens when the system is broken is that the parathyroid hormone stays elevated even in the setting of high calcium. And that's the classic definition of primary hyperparathyroidism. So when we see patients, most of the time they're coming to me with an elevated calcium level. And the first thing we do with that is then we check a PTH level. If the PTH and the calcium are both elevated, that's consistent with either primary or tertiary hyperparathyroidism. And we'll talk a little bit about what tertiary is as well. If it is mildly elevated or even what we would call inappropriately normal, again, most likely we're talking about primary or tertiary hyperparathyroidism. And then in the rare scenarios where the PTH is very low, but the calcium is high, we're looking for other causes of increased calcium. Where I think a lot of people miss the diagnosis, at least in higher income countries and highly developed regions, is you don't even have to have the lab values be completely out of the normal range to have primary hyperparathyroidism. A calcium just at the upper limit of normal, along with a parathyroid hormone just at the upper limit of normal, that is abnormal. Because again, if the system is functioning properly, we're going to have opposite levels of those values. And so we're very discerning when we're looking at the lab values and treat aggressively. So what we didn't talk about yet is secondary hyperparathyroidism. And secondary hyperparathyroidism is what we would consider most of the time an appropriate response by the parathyroids in response to some sort of a stimulus. So I explain that typically primary hyperparathyroidism means the problem is with the parathyroid gland. That's what's broken. Secondary means that the poor parathyroid is just doing what it's supposed to do. It's responding to a low calcium, usually, or a low vitamin D. And what that does is it causes all of those parathyroids to get enlarged and hyperactive. So by definition, we're talking about hyperplasia. The two most common causes that we see are chronic kidney disease and vitamin D deficiency. Vitamin D deficiency can be very tricky because it's also affected in primary hyperparathyroidism. So if somebody has a normal calcium and a high PTH, we're curious if it could be repleted with vitamin D. We want to see what happens to the parathyroid hormone. Does it go down? Is it suppressible? If somebody has a high calcium, a high parathyroid hormone, and a somewhat low vitamin D, that's actually probably just due to the activated vitamin D being churned up by the primary hyperparathyroidism. So there's lots of things you can do to kind of further investigate that. And as we alluded to, tertiary hyperparathyroidism, I think, is one of the hardest things to diagnose. And the way I think about that is it's basically the secondary cause got fixed. Either the vitamin D deficiency got repleted or the kidney dysfunction got treated, usually with a transplant. And what happens is that nobody told the poor parathyroids they don't have to run that fast anymore. They don't know how to stop because they've been so hyperactive for so long that they are now autonomously functioning and they can't stop. So we see that a lot here after kidney transplant. And one of the questions that I will have for you guys is, how many of these patients that we have on dialysis do we even anticipate going on to transplant? Because that can affect the extent of surgery we want to do. If we know there's no chance of a transplant, often we're a little more aggressive in the amount of parathyroid tissue that we resect, because we know they're going to be exposed to continued prolonged stimulus with the kidney failure and dialysis. If we know they're bridging to transplant, we want to make sure that we leave enough behind that when this gets fixed, they still have functioning tissue, but they don't proceed into tertiary hyperparathyroidism. So I love this figure because I think it demonstrates nicely what we expect to see in the operating room. So on the left, you can see the most common version of primary hyperparathyroidism, which is where one big parathyroid kind of goes rogue and secretes way too much PTH, no longer listens to the calcium signal saying, hey, we've got enough, and it doesn't shut off. So the biochemical profile that you see is an elevated parathyroid hormone, an elevated calcium, and usually a decreased phosphate. In secondary, however, all four of those glands are responding together. They're all responding to some sort of physiologic derangement, usually a low calcium from chronic renal disease, and they just get over elevated. The calcium's typically low, the phosphate's high, and the PTH levels are exceedingly high. We'll talk a little bit in a minute about what the guidelines currently recommend for thresholds at which we should consider intervention for secondary hyperparathyroidism. And finally, tertiary can be any version of this. Sometimes it is one gland that's really big. Sometimes it's all four. Sometimes this diffuse hyperplasia that we see in secondary has now just developed completely autonomous control, and all four of the glands are enlarged, but they're different sizes. We see all versions of this in the operating room. And I kind of chronically tell our fellows here in training that there is no logic to this disease. There's no rhyme or reason, and I have seen every version of parathyroid anomaly that you can probably think of, and I'm still consistently surprised in the operating room. So for a background, secondary hyperparathyroidism is pretty prevalent. By the time patients are in stage 3 or 4 CKD, about 50% of them are going to have some level of almost symptomatic secondary hyperparathyroidism. 90% of patients that are considered end-stage renal disease will have this as a normal physiologic response to their kidney failure. After transplant, the older numbers say about 7% develop tertiary hyperparathyroidism. I think it's probably higher than that. But we have to really chase down people for referrals and get more treatment for this to really get, I think, what would be more accurate numbers. Almost everyone has 4 parathyroid glands. But in the setting of secondary hyperparathyroidism, where we've had chronic stimulation of the parathyroids, at least 30% probably have what we would call supernumerary or ectopic glands. And that's usually down in the thymus. And that's usually, again, every sort of stray parathyroid cell that's in the body has just been stimulated to the point that now it almost looks like a gland. Embryologically, if we go way back to the beginning when we're forming, parathyroid glands actually start very high in the neck. They have to descend down, and then they actually crisscross each other to park it right by the recurrent laryngeal nerve. But all along that pathway, there can be a few stray parathyroid cells. And in the setting of extreme stimulation over the years, that can actually become a visible gland or a parathyroid rest. So when we do secondary hyperparathyroid surgery, we often do things like a thymectomy to make sure that we're not leaving behind, something that's like an extra gland. My record for distinct glands taken out of somebody is 7. And that was in a primary setting, but that was in MEN1. And so again, in the setting of chronic long-term stimulus, even a few parathyroid cells can become something like a gland, which is also why the surgery and the dissection is so meticulous, because parathyroid cells are one of the few cells that can just grab onto something and start a blood supply and produce. You can have something called parathyromatosis, where you have a seeding of parathyroid cells throughout the neck. So we're very meticulous in our surgical treatment of these glands. They are very delicate. In terms of what we see for patients with CKD, it's usually in the stage 2 and stage 3 levels where we start to notice a significant increase in the parathyroid hormone, and then changes in calcitriol, which is essentially activated vitamin D. Stage 1, we don't really see it that much, nor do we intervene. By the time we're in stage 3 or 4, though, we're usually really looking at a level of disease that is significant enough to merit consideration, at least, of surgical intervention. And most of these are all pulled from the parathyroid guidelines, which I'm happy to are freely available on the web from the AAES, which is the American Association of Endocrine Surgeons. We have a dedicated new guideline for secondary and tertiary hyperparathyroidism. So why should we think about treating this, right? What's the problem with elevated parathyroid hormone? The classic teaching is over here on the left, which we all hear in medical school, which is stones, bones, groans, and psychiatric overtones. It's almost everything. How parathyroid hormone affects all these things in the body, I will never know. It has widely systemic symptoms. And I tell my patients that almost anything can get better after parathyroid surgery. I also have to give them the disclaimer that there are no guarantees, because if you look at the spectrum of symptoms here, it's everything from, trouble sleeping, memory concentration, fatigue, aches and pains. I think at least these days, most of us have some level of some of these symptoms. And so I say, I will take credit for anything that gets better. However, if it doesn't get better and we're able to biochemically cure things, it's probably not related to the parathyroids. But I have certainly seen very, very strange symptoms get better. So I never say never. Again, there is no rhyme or reason to parathyroid disease. Unique to secondary hyperparathyroidism and in the kidney dysfunction state, we often see patients with increased pruritus, proximal muscle weakness. In severe cases, this can progress to things like osteitis fibrosis cystica or calciphylaxis, which thankfully is fairly rare. I've only seen a couple of patients with calciphylaxis, and in that case, it is sort of a palliative treatment to do a parathyroid surgery and try to treat that. So who should get it? Especially as we start to move this into the region and try to train this surgery in, who would we be looking to refer? The 2017 KDIGO guidelines really target people who we want to avoid hypercalcemia. We want patients who were having trouble managing their phosphate. And then for parathyroid hormone, the classic teaching is anywhere that's above like 9 times the upper limit of the assay, those patients have maxed out their medical management and should be considered for surgery. We know that we're not going to get them into a normal range or a low normal range for parathyroid hormone, but we want to get them close in terms of surgical treatment. Medical management is certainly the preferred approach initially, and that it can include things like phosphate binders and dietary restriction, vitamin D, helping to increase some of this. And then at least in higher income countries, there are things like calcimimetics, which is cinacalcet or Sensipar. That is not a favored drug. It has a lot of side effects. It is extraordinarily expensive. And I can tell you from the surgical standpoint, it actually affects what the parathyroids look like. Somehow it causes them to become incredibly firm, necrotic. And for the few patients I've operated who have been on cinacalcet for any period of time, I've actually, in at least one of them, thought I was dealing with parathyroid cancer. So it completely devolves what the parathyroid tissue looks like. And it's also one of the first scenarios where I've seen, at least in our country with insurance requirements and pre-approvals, it's one of the only scenarios that I've seen insurance companies deny the drug and point out and approve surgery, saying surgery is more cost effective and better in the long run in terms of treatment. So in Australia and New Zealand, you can't even get these calcimimetics anymore because, again, surgery is proven to be a much better option for the patient. So we certainly want to think about that. But in general, if we feel like we have maxed out our medical management, that's the time to start thinking about surgery for this disease. So we're looking at patients with CKD with increased PTH. We've treated the modifiable factors. Usually that is calcitriol. And again, we're going to cross out calcimimetic because these days we're not using that very much. And then if we've got persistently elevated PTHs above, 9 to 10 times the upper limit of normal on whatever assay we're using, for us, that's between about 600 and 1,000, they should be referred to at least discuss the pros and cons of surgery. Anyone who has progressed to hypercalcemia certainly deserves surgical treatment because, again, prolonged hypercalcemia has plenty of complications on its own outside of the consequences of high parathyroid hormone. What we see at the cellular level, we kind of alluded to this with talking about secondary and tertiary hyperparathyroidism, is a tremendous proliferation of the parathyroid cells here to the point of nodular hyperplasia. And the problem with that is when we develop nodular hyperplasia here, that does not regress. If you're able to fix the underlying secondary cause, hyperplasia will regress a little bit, like this diffuse hyperplasia that we see here. But if we've progressed into severe secondary and we have nodular hyperplasia, that's not going to go away if we fix the secondary. So even if these patients are able to move on towards kidney transplant, they're going to have prolonged problems from their parathyroid tissue. We know that parathyroidectomy improves all of the lab parameters that we're interested in measuring. This is mostly looking at calcium and PTH from the guidelines. And again, I'm happy to share any of these articles with anybody who needs them if you don't have access to them. But basically, even intraoperatively, especially for parathyroid hormone, if you have the ability to test that, the fall in the lab parameters is marked. It also improves things like bone density in osteoporotic and even osteopenic patients. And so for both primary and secondary, a lot of times the discussion that I'm having with the patient is, this is a modifiable cause of end organ damage. And the old guidelines would say things like you have to develop a kidney stone or have a documented decrease in your GFR or have osteoporosis before you should be considered for surgery. But in the setting of a high volume surgeon where you can do the operation safely, personally believe that we shouldn't wait until we have end organ damage to fix something that we know causes end organ damage. And so we fix things much, much sooner, much more aggressively than a lot of the guidelines have traditionally said. And thankfully, most of our guidelines are starting to recognize that. So again, it's hard to prove increased bone density, but we can do it. So the big question everybody has is, isn't surgery risky? I mean, surgery for a lot of people feels like the most objectionable possible alternative you could have is, I'll do anything as long as I don't have to have an operation. And I think I'm put on the planet to prove that that's not necessarily the case, and surgery is not always the most objectionable alternative that you could have. So some of the things that we started thinking about as we've worked towards trying to bring this into a resource-limited environment is things like our ability to follow patients long-term, ability of imaging in terms of what we need for both pre- and post-operative assessments, things like a lack of equipment, follow-up, or limited inpatient abilities. And these are some of my older pictures from places that I've worked in Kenya and done some of this mostly for thyroid surgery. Traditionally, secondary hyperparathyroidism is associated with people who have been on very, very long-term dialysis and often have something that we call hungry bone syndrome post-operatively. Luckily, in the setting of high volume surgeons, we can actually minimize this. And my goal would be to take something similar to the protocol that I use here and bring that into the region. And that is essentially a 1 to 2 day stay with aggressive pre and post-operative oral supplementation. And the goal would be that, as we have here with our complication rates, which are all less than 1% for things like a hematoma, a recurrent laryngeal nerve injury, a wound infection, or a readmission for hypocalcemia. So I can see the questions forming, hopefully, and the imagination that I have would be, how do we reduce that risk? So the first thing we do with our very aggressive protocol is that we stop any sort of calcium mimetic like cinacalcet, and then we really aggressively initiate calcitriol and calcium, which for us is just Tums here, calcium carbonate, easy to acquire, easy to take. And doing that for about 7 days pre-op, multiple times a day, will reduce hungry bone syndrome dramatically and dramatically decrease our length of stay. If intraoperative nerve monitoring is available, it is ideal, just because it can help us recognize a potential nerve injury. That being said, if patients have a normal or near normal thyroid size and no other risks, it is feasible to do this operation without nerve monitoring. I've certainly done it. We just have to be acutely aware of any anatomical variants that we could encounter. We also do an aggressive postoperative oral supplementation to minimize the need for IV calcium. What we have seen traditionally is that patients are put in the ICU and put on a calcium drip, and then we watch their calcium drift down, and we'll add a little extra to the drip, and it takes weeks to kind of optimize them. And our approach here is that we very aggressively start with oral medications, and we will add a little bit of IV supplementation if we need it to, but our goal really is to titrate up the oral medications as fast as we can to stabilize their serum calcium, because they're going to need those oral medications for a while post-surgery. But if we reach what we need for our oral supplementation to maintain, then we don't have to have IV calcium. We don't have to have prolonged inpatient stays. So we just can't be afraid to be very aggressive with the amount of medication we give by mouth. We can also plan for something like a high calcium dialysis bath if needed. And that's something that I think in this region we would really want to at least have available as an option, because again, a lot of patients can go home, return to their routine dialysis schedule, and just optimize adding some calcium in during their dialysis if that's possible. And that's something that we've done here with our nephrologist as well, although we always sort of have to have the discussion and plan for it pretty far in advance. So again, patient selection for this is absolutely key, and planning for the things that you'll need to keep that patient out of the hospital is also really important. Careful patient selection is going to be the key. I think, if we have somebody that's been on dialysis for 15 years, that's not the person to try to do this very aggressive outpatient protocol on. I can see that being a person that would fail outpatient management. So we want to be sure we're planning as far in advance and we have really involved and dedicated patients for this type of surgery. In terms of imaging, what do we need? Realistically, we don't need anything up front. Imaging is really only for operative planning. It doesn't have anything to do with the diagnosis. And most of the time, a handheld ultrasound is all that we need, for two reasons. One, I want to assess the thyroid. I don't like surprises, and so I certainly don't want a massive thyroid goiter in my way as we're looking for these parathyroid glands. And two, it's really great if you can actually see most of the glands. For secondary hyperparathyroidism, often you can, and you can know exactly where you're going for. That also helps you in the operating room in terms of deciding how much and what gland are you going to leave as a surgical remnant. These patients inherently need a 4-gland exploration. Image visible parathyroids on ultrasound, and they're still hyperplastic in the operating room. So basically, what we were talking about with this slide is that most patients with secondary hyperparathyroidism, essentially all of them, are going to require a 4-gland exploration. Even if the imaging suggests one side or one gland is bigger than the others, often what we're going to find is asymmetric hyperplasia. The goal is to find all 4 glands before you take anything out. And the preference, if you get to choose, is to leave an inferior gland as your remnant. And the reason we say that is that anatomically speaking, that gland is located anterior to the recurrent laryngeal nerve. It usually has a longer vascular pedicle, and it's just safer to save if you might need to ever be back in that neck for any reason. It also depends on what the glands look like in terms of what you might do for a true subtotal. If you're taking 3.5 glands and you want to cut one in half and leave, half of a gland as a remnant, you want a gland that's maybe a little elliptical in shape to divide. Those tolerate division better than a round little gumball that isn't going to be happy being chopped in half. So we try to find everything. We look at everything and say, okay, this is the gland I think I want to leave as a remnant. And so what I try to do then is go ahead and divide that. I take my piece off, put that for pathology. And then as we go to take out each of the other glands, I look back at that remnant and make sure it's still well vascularized, that it doesn't look dead. It doesn't look like it has a big hematoma on it. Because as we move through then sequentially, I can always choose another remnant if I have to. But my goal and my definition of a worst case scenario would be leaving someone with no functional parathyroid tissue. So I do err on the side of being conservative in the operating room, despite how aggressive we're talking about being in terms of taking patients to the operating room. This is an intraoperative photo of what asymmetric hyperplasia can look like. And again, you'll notice all of these glands are slightly differently shaped. And so in particular, this one on the right upper gland is very difficult to find. Sometimes it likes to hide very deep behind the thyroid and tuck itself down behind the recurrent laryngeal nerve, which is drawn out here on the picture. Had we been able to see that ahead of time, that might have been a very good remnant, because you'll notice how elliptically shaped it is. There's a good place to divide it. But instead, the right lower gland was very normal in size, and so that was left in place with a clip to mark its location. So I always try to plan what would make us happiest in the future. I tell every patient what I'm going to do in that operating room is designed to make future you and future me as happy as we can possibly be. And so that's often what it looks like in the setting of these larger hyperplastic glands. Anatomically, we've already alluded to this. The recurrent laryngeal nerve runs right between those glands. And this is just what it ideally looks like in the operating room if we're following the anatomy rule book. But few things ever do. And so we have to just be cognizant that parathyroids can be in any number of locations. This is a classic picture published by my fellowship mentor from MD Anderson, showing all the various locations of parathyroids. They can be intrathyroidal, they can be in the thymus. I have found them, I found one in the pericardium one time. We clearly didn't find that at the original surgery. My partner just did one that was in the piriform sinus. So these little guys are truly rogue, and can be anywhere in the neck. They can be outside of the neck. And so there's a ton of intraoperative decision-making, just knowing that our goal is to be as safe as possible. This is not cancer typically, and this is not imminently life-limiting. So I do feel like it's the old saying where, the enemy of good is better. We want to do enough, but we certainly don't want to do too much. And so that's pretty much how I think about parathyroid surgery. This is a reference to our most recent guidelines for this, so secondary and tertiary hyperparathyroidism. This is freely available, open access, written by a combination of surgeons and medical endocrinologists. So it really, I think, does provide a good representation of how we think about the disease. And with that, I will stop sharing, and I'm happy to discuss or take any questions that you guys have.
Thank you very much. I will say, through my partnership with Lloyd, I've been exposed to a few patients with this disease, and one of them was actually on COSECSA. He was in Tanzania. And I wonder if maybe that's going to become more common, maybe as it gets pushed out of the developed world, the drug companies would start bringing it to Africa and maybe saying things like, it is harder to do the surgery here, so this is justified in Africa.
I could certainly see that. And my hope is that perhaps we can kind of cut them off at the pass and prove that surgery is safer. And, again, just because we have a medication for it doesn't mean that's the best option. Cinacalcet comes with tremendous side effects. Most of the patients I have encountered who have taken it say, I don't like this, it makes me feel terrible. And again, it's extraordinarily expensive. And from a cost standpoint, I think that this is another example of something we look at a lot in the field of global surgery, which is proving that surgery actually is often more cost effective than a lot of other interventions. When you look at it from the outset and you think of everything you have to have for a surgical ecosystem, things from anesthesia to postoperative care to, all of the management, it looks extraordinarily fancy and expensive, but in reality, it can be done quite cheaply and quite cost effectively. So I see a question in the chat about the practice of removing all 4 glands and then injecting one into the arm. That's certainly done. I think that you have two things for that. Number one, I would do that if only in a scenario where I thought somebody was never going to get a transplant and they had extreme parathyroid symptoms. Typically, if I'm going to do an auto transplant, I don't inject it. I actually make a small incision in the arm mince it up and put a couple of auto transplant pockets so that we can be sure it takes. I actually think that when you do that, when you do a total parathyroidectomy, you're committing that person to several months of calcium and calcitriol management while we wait for that auto transplant to kick in. And there's not a guarantee that it will. So I think that's a gamble. And even for our patients with hyperplasia, our patients with hereditary, multiple endocrine neoplasias, we've gotten less aggressive at doing something like a total parathyroidectomy with transplant and more aggressive at ideally trying to leave a remnant in its normal location in the neck where it should be. I think you also have to balance that, though. Everything in this operation is a balance. Balance that with your risk of recurrence. And so that's why, at least for me, I do a lot of thinking about, where do I want to put my remnant? How do I want to leave my gland on, the side, say somebody has a thyroid nodule, but we're not intervening right now. I want to leave my remnant on the opposite side from the thyroid nodule. So if I ever have to go back to the thyroid side, I'm not putting their only parathyroid at risk. If I ever have to go back for the parathyroid, it's safe and tucked in on the other side. So the calcium loading pre and post surgery, is there a particular way to prescribe this? So there is a way that we do it. We typically do, we are using about 1,200 milligrams twice a day. I don't have a strong preference for with versus without meals. Depends on what the patient tolerates. Some people are very bothered by the calcium carbonate. They don't like the chalky taste of it, or they find it constipating. So I don't think it matters in terms of meals. The calcitriol, we just have them take it at the same time. So yeah, we have a whole written out protocol for how we do this that I'm happy to share, assuming that once we do this in Kenya, it works well and it looks like it's something that's viable in the region. Hopefully we can operationalize that in many countries.
Yeah, I agree with you, Dr. Long, that cynic acid has been a huge challenge. We get it from India, it's extremely expensive, and then the stocks get over, and again, we get it from there. And quite often they'll end up ultimately not having the drug, and surgery definitely is the best option for us out here. The other thing is the post-op stay, cutting the post-op stay, especially managing the calcium, that was a challenge, I think. And as far as I know, that has been a challenge. So I think that would be a great change in the region, and a big, especially like people coming from a distant area coming in for surgery. That would be staying at the site post-op would be very expensive. Relatives and the patient together. That would be a huge change. And of course, we don't have people who do the surgery. That's the other huge thing, and that's something really grateful to Dr. Davis for having taken that initiative up and, encouraging the whole process and bringing you along. So that will make a big change indeed.
Absolutely. I also just noticed that there's a couple of questions in the Q&A. I was looking just in the chat, so I will briefly address those. So in the picture we shared with one gland being left after surgery because of normal size, is there a chance for it being hyperplastic in the future? And I would say it's hyperplastic now. I mean, by definition, in this disease, everything is hyperplastic. You're sort of playing like surgical Goldilocks, trying to get it just right. If it's really big, I'll take a piece of it and only leave a half or even a third of a gland. But it's a constant balance between taking out too much and not taking enough. And so we walk a tightrope in that operating room, and it's often deciding between, okay, how old is this patient? Problems with a remnant that's too big can take years to develop. It might not take that long. So again, we're trying our best to estimate what we think that patient would need. And it just comes with a lot of practice. And we don't always get it perfectly right, but that's why I always do say I would rather err on the side of a little too much being left behind rather than not enough. And I also find that most of my nephrology colleagues have appreciated that as well. It's easier to manage mild persistent hyperparathyroidism than it is to manage permanent hypoparathyroidism. So that's sort of the balance that we're walking. The next question said, any experience of parathyroidectomy in post kidney transplant recipients with features suggestive of tertiary hyperparathyroidism? Yes, lots of it. We see it a lot. And the old guidelines, you can kind of predict who's going to progress into it by the people that are already starting to become hypercalcemic prior to their transplant. I also see a tremendous amount of people who, if we go way back, if I have the ability to go way back and audit their labs, there's a fair number of people that had primary hyperparathyroidism before they went into renal failure, whether that was the cause of their renal failure or whether that's just something that was going along in the background. So we like to talk about them like they're three separate diseases. I think they're all three kind of the same disease on a spectrum, and you can actually have more than one version at the same time. You can have primary and secondary at the exact same time. You can have secondary and tertiary at the same time. I operated on one woman who had what we thought was terrible secondary, PTH of 2,500, had been on dialysis for quite some time. And in the operating room, I found 3 plump glands and 1 massive gland that I'm talking was like the size of a sausage link. So clearly she had a different version. We took that 1 gland out and she dropped from 2,500 to 200. I left the other 3 in and she did great. So again, it comes with finding, knowing what you're finding in the operating room and realizing that all of these, you can have multiple versions of this be true at the same time. Then my last question so far says, what radionuclide studies can be used in the assessment of hyperparathyroidism? So you can do things like a sestamibi scan if needed. We don't really do that as often because I find that thyroid nodules are often positive on a sestamibi scan. We've done this intraoperatively as well, but I think, at least in our setting, radionuclide scans have actually been replaced more by autofluorescence studies. There's some really innovative tools and probes that we in the operating room that rely on parathyroid autofluorescence. There's something called the PTI that was developed at Vanderbilt that's incredible. But as with everything, the more tools and things you use, the more expensive it gets. And so I have used it. We have the machine here at the University of Wisconsin. I use it rarely, but most of the time I find the imaging doesn't really help me if it's in the neck. The places that imaging has been helpful for me is if we have, on the rare occasion, we have a failed parathyroidectomy, when we're looking for a gland that is truly, truly ectopic, meaning nowhere that I could have gotten it from a cervical incision. And from the neck incision, we're able to get usually the thymus glands. I've gotten retropharyngeal, intrathyroidal. We can, do that mostly from a neck incision. So I'm kind of an imaging minimalist, which I think has helped me get much more comfortable just with 4 gland explorations. So, and then the last question is, again, the reason why we don't put it in the arm is no longer preferred. It's mostly that if we don't have to do that, we try not to. I've seen 2 things. An auto transplant into the arm is not, it's got a high percentage of taking, but it's not 100%. And the other reason is that when you put that in the arm, a lot of times then when the patients get their labs drawn, if they're drawing it from the same arm as the auto transplant, your labs are always going to be falsely elevated because you're drawing directly upstream from your auto transplant. So sometimes for people who have forearm grafts, I have to make them go to the lab and make sure they draw from the left AC and from the right AC to compare the 2. It's a nice way to test if the auto transplant is working, but it's also a way to rule out, they don't have, recurrent disease. They just have a functioning graft. So I do it, especially for reoperations and things like that. And if I'm worried about the viability of anything in the neck, if I think there's nothing left in the neck, I will 100% put it back in the arm. It's just not the most commonly used approach.
There are a few more questions in the chat. There's one of the participants asks, the PTH is more than 9 times elevated, but the calcium and phosphorus are within normal range. What would you do about that?
I mean, I'm a surgeon, so I would like to operate. But I think that depends on the symptoms that they might be having. If they are, quote, asymptomatic, which I think is rare. I truly think that like an asymptomatic patient with PTH levels that high is almost unheard of. But that's not somebody that I would necessarily like chase down the hall with a knife. But if they have symptoms and they are interested in surgery, I think surgery can be thought of as something like resetting the clock. You're not necessarily going to cure them, but you're going to mitigate some of those symptoms that they would develop. Because whether they feel it or not, they're still having the deleterious effects of that level of PTH on their bones. And so I think it's a fair thing to have the discussion.
Then another question is a little bit more about hungry bone disease. Can you talk about hungry bone disease a little bit more?
Yeah.
How does that work and what do you do about it?
mostly you try to prevent it. It's always a surprise. We occasionally still have people that have just significant calcium needs post-surgery. Things that we look for. So in primary, you usually see it in like somebody comes back for their 2-week post-op labs, and despite a perfect cure in the operating room and a PTH that we ended with like 15, which is just great, they'll come back and their PTH is 100 post-op, and you're like, wait a minute, I thought, you know. So that's just the scenario of their bones starting to resorb some of that calcium. And then what happens is exactly what you would expect physiologically. Their bones resorb calcium, their serum calcium drops, whatever remaining parathyroid hormone or parathyroid gland they have is like, oh, low calcium, I have to rev up. So they rev up again. And so you just kind of have to wait it out. That's why even for all of our patients, we do our typical protocol here is 2-week post-op appointment and 6-month post-op appointment. And for almost everyone at 6 months, the hungry bone syndrome has resolved itself. In the setting of secondary, it's totally going to depend on how long they've been on dialysis and what level of calcium depletion they have. And so I think that's something that we're going to learn as we do this, and something that I would preferentially say, that's why I think we start with patients maybe who haven't been on dialysis as long, because I think that decreases our chance of somebody needing significant calcium potentially inpatient with an IV.
I have a question of my own. I've been talking with Dr. Lloyd about this a little bit. In our setting, it's difficult to get PTH levels. Sometimes we have to send them out. Maybe some of the people on this call don't have access to PTH at all. What do you think about alkaline phosphatase as a surrogate? Is it reasonable to say, hey, there's a lot of bone turnover going on because the alkaline phosphatase is high, therefore we should operate if they have symptoms and other things that suggest secondary hyperparathyroidism?
I certainly think it's reasonable to use it. I think that you could, at least in terms of the intraoperative and the immediate post-op management, I think you could do it without PTH testing. I mean, for me, on my 4-gland explorations, the way I use PTH testing in the operating room is we send a baseline level when we start, and then I send one in the recovery room. But if I can confidently identify all 4 glands, which most of the time we're able to do, I do it based off of visualization in terms of how much I resect, and there's nothing that would make me take more. So I would say, I think it's not unreasonable to do it without PTH testing.
But I mean, like, if you have 100 patients on dialysis,
Oh yeah,
and you don't want to send 100 PTH levels, could you check alkaline phosphatase on them and then send PTH on the ones that are elevated, or maybe just do your surgery based on the alkaline phosphatase? What do you think about that?
I think you could. I've never done it before. I think I would have to like look into, you know, there are some bone specific alk phosphatase tests that you can run. That might even be a question I would actually think about in terms of asking some of our medical endocrinology colleagues, because, you know, I haven't done it, but it seems like a reasonable idea is about the best I can say, you know, just thinking about it.
That might be a research angle for us in Africa here, don't you think, Lloyd?
Absolutely.
Yes, because there are isoenzymes for alkaline phosphatase, and we need to see how much they would contribute to the elevation of alk-phos. Of course, it will be the bone, but there are other isoenzymes we need to actually measure when we do research, I think. So ELISA PTH, that would be the standard that is done, or are there other methods of measuring PTH?
So we do the intact PTH here.
Yeah.
But it's, you know,
ELISA?
again, yeah, I think so. We have a couple of different assays. We don't have the one that you can actually like have as a point of care in the operating room yet. We keep trying to get that, and they won't let us have it. So we still send it to the lab. But no, I think it's, you know, I definitely can see how high PTH is a huge pain for nephrologists in the region, and I think that yes, I would love to train as many people on it, and again, focusing on really on the intraoperative decision making, because the technical component, once you know what those parathyroids look like, you can find them.
And coming to training now, there are a lot of people who actually would come on board now. See, we have leading people in nephrology. We have Dr. Tahir, we have Dr. Shanashando here, Dr. Narendra, Dr. Agri. So across, that is Kenya, Botswana, again, Zambia, Rwanda, also Tanzania. So how would you go about doing this? I mean, and how long do you think it would take, training up one center, and what are the things that we would do?
I mean, I think that the best thing you can do is probably have one kind of dedicated, committed surgeon that's interested in technical components of it. So if there's one person that I can work with, doing at least 3 to 5 cases, I'm, again, happy to frequently come back as needed. But it's not, I think that the finding of the parathyroid glands is reasonably easy once you know what you're looking for and what they look like. And, just doing a series of that, seeing it over and over and over is pretty reasonable. I think it comes down to looking at them and deciding, okay, intraoperatively, how much am I going to resect and how am I going to do that? And again, I think that, the more cases we can do, the better. But I could envision if we could have a week of stacked cases in each location, kind of planning, then we can move forward with it. But at the risk of sounding like it's not a hard operation, because it is a hard operation, the technical components are very translatable. General surgeons are well trained in doing this. People in the region here are phenomenal surgeons at taking out thyroids. And so, the technical components I think will translate well. I think it's just mastering the protocol, sort of the planning ahead and behind, because it's not common that we have a lot of general surgery cases where we are doing a week of intensive preoperative prep and a week post, kind of following that. And then having super close collaboration with the nephrologists, because there will be a point where the surgeon will need to transfer it over to nephrology management, and just knowing how much oral supplementation to give.
I will say, as a self-plug here, that Dr. Long is going to be at Kajabi Hospital the first week of April, and we are recruiting patients for that. I do have one coming from Tanzania next week. So, but if you want to talk to me about sending some patients, I think the more we can get for her, I'm hoping we can get 3 to 5, but if I could get more, I'd be overjoyed. So I'm going to be working on that in the next month here.
Yeah, because I would say,
Dr. Salashando.
In practice here is 3 to 4 parathyroid surgeries a day. So
thank you very much. I just wanted to say thank you very much for the lecture. It's not much of a question, but just to give a background, I think we've been doing a lot of dialysis in Botswana, mainly because our government has been very supportive. So we have a lot of patients who are old on dialysis. We're not doing as well in terms of transplanting these patients. So yeah, my biggest pain is their pain. My word round is, doctor, my bones are killing me, mainly with tertiary hyperparathyroid. So yeah, I found the lecture very practical. We do have some general surgeons that are doing these surgeries now and then, but they probably don't do a lot. The outcomes are not so great at times. So, it's not a great surgery for surgeons to do, because sometimes the PTH stays high and the patient's like, oh, you want me to go again? We did that the first time. Why is it not working? But I do think that, we can improve, and I'm looking forward at getting some of them to come for more training when it's available, because I think, there's always a bit more we can learn, do things better. But otherwise, thank you very much for the presentation. Thanks.
Thank you. I'm looking forward to it. Like I said, it may take me some time to get around to everywhere, but I'm certainly willing to come if there are surgeons willing to learn.
Yeah, we need a local champion surgeon is what it sounds like.
Kajabi could also be a point, a center of excellence that we could actually send youngsters who are interested to learn to.
Sure.
I would love to see that happen. I'd love for one of our young surgery consultants to take this up and be the champion of this.
I love it. Well, thank you guys so much. I am so excited for this and looking forward to great things in the future.
Yeah, thank you.
Thank you.
Thank you. I just want to say thank you, Dr. Kristin Long. Thank you, Dr. Richard Davis, again for moderation and also for your insightful presentation. I think, yes, as you said, more capacity building is needed, and soon enough we'll cover the whole map of Africa with the much needed skill. So on behalf of Africa Healthcare Network and our panelists, I just want to convey my thanks. I wish to have you again soon so that you can again take us through more topics on this and even other complicated endocrine surgeries. Thank you and have a good evening.
A follow-up version of what we've done, probably end of the year. That'd be great to see what progress we've made. That would be really nice.
Yeah, I like it. I like giving us some targets for accomplishment. So
yeah, we're collecting the data. We'll collect all the data and report back how it goes.
Amazing. Thank you guys so much. Y'all have a great night.
Thank you, Kristin. Good night.
Thank you.
Thank you. Good morning.
Thank you.
Bye.